Okay. Dear colleagues, dear friends, my name is Pierre-Emmanuel Falcoz. I'm the current ESTS database director, and I'm very pleased today to have the opportunity to open with my colleagues and especially with my co-chair, Dr. Salati, this year 2018 database session. Why am I pleased? Not only because of the huge attendance, no, rather because of the quality of the scientific program we will deliver today, the quality of the speakers for sure, and I'm sure you will enjoy, at least for those who are interested in data and in data quality. I will talk a few seconds and use my privilege of chairperson to repeat a few rules. I encourage all the speakers to strictly stick to their time, and we will have time, I'm sure, for a few questions at the end of each talk. At the end of the talks, the very end of the session, I will, in company of our Secretary General, Alex Brunelli, we will together deliver the accreditation award for this year. As you will see, there are five centers that succeed in the accreditation process. I really hope you will enjoy the session. I will now give the microphone to my colleague, and he will say a few words.
Well, it's just to thanks all of you for the attendance, and I think we can just start with the first presentation, that is the one of our director of the database, that is going to give us some insights about the database annual report. Pierre-Emmanuel.
Sorry to monopolize the microphone. So, as I told you, I'm pleased to give you my report for this year on behalf of the ESTS database committee. I have no relevant conflict of interest or financial disclosure to state. The aim of my report is twofold. First, as each year, I want to shed light on what passes on during the past year. And also, the second aim is to provide an epidemiologic overview of the thoracic surgical activity in Europe in order to establish best practice benchmarks. How is the ESTS database functioning? A few words of history. It was founded in 2001. It is based on a free and voluntary participation. It is currently running on a K-data platform with all the mandatory security and backups. Importantly, it is fully compliant with the new general data protection rules that are available since 2 days now. At another level, national level, international level, the ESTS database cooperates with two national registries, the French and the Hungarian registries. We have also a strong collaboration with the STS, and we regularly publish papers on focus topic. And we have set up, and we are happy to our new partnership with Brazil. How is it built? A core data set dedicated to lung cancer, which is our main goal and our main specialty. It covered 80% of the patients which are currently in the database. Around that strong core data set, we have developed over time 4 satellite databases dedicated to a specific topic: mesothelioma, thymoma, chest wall, and neuroendocrine tumors. This year, I have a new one dedicated to tracheal registry. It is currently in a pilot phase, and it will be ready to go in the next year. And next fall, it will be open to several centers that were specifically picked up because of their huge number of tracheal activity. This tracheal registry is currently led by Ricardo Terra from Brazil and Michele Salati from Italy. This year, it is the 9th edition of the Silver Book, compiling 11 years of prospective inclusion. If it has not been done already, you can download on the meeting app a short version of the Silver Book, short version restricted to the lung cancer activity. For ESTS member, ESTS member can download a password-protected full version with the complete epidemiologic analysis on the ESTS website. Some data now, some raw data now. 2018, we are now entering in a very mature phase, plus 15% of data since last year. I am proud to announce 132,000 patients in, thanks to the French input in 2011, the Hungarian input as a whole nation. We currently reach 104,000 lung resections, yielding to 58,000 lobectomies. We have deliberately chosen to perform the analysis on European data only for more reliability and consistency. How is the Silver Book structured? The first part is dedicated to European cumulative activity over the last 11 years. We made a particular focus to lung resection, types and diagnosis, and so on. And particularly at the end, we dedicated some pages to the outcomes, taking into account two important variables, quality variables, 30-day mortality and prolonged DLCO. And we have chosen also to do the analysis over two periods, the first one until 2012 and the last one. I will give you now a few examples. For example, taking into account the VATS. VATS as a proportion of all lung resections, you see that nowadays, at the end of 2017, VATS was undertaken in 30% of all lung resections. That is plus 2% since last year. When dealing with VATS as a proportion of lobectomies specifically, we see a dramatic increase of VATS over time. And in the last period, VATS reached 37.3% of all procedures done by lobectomy, for lobectomy. Importantly also, at the end of the first part, we have added quality analysis on hospital mortality trending thanks to CUSUM analysis. CUSUM is only the reflect of expected risk adjusted minus observed risk adjusted mortality. When dealing with VATS, you see look on the right of the slide. You see that over the last period, the curve is continuously improving, increasing, meaning a quality improvement, a decrease, an increase in lives saved, so a decrease in mortality. Same thing when we have a look at the no VATS procedures. Over the last period, on the right, you see a continuous, as a general trend, a continuous improvement in terms of quality because of an increase in lives saved. This decrease in the curve on the left, meaning an increase of mortality and a decrease in lives saved, as a corollary, simply means a shift over that period, a shift toward VATS, with the most difficult cases done by thoracotomy, by no VATS, that is thoracotomy. Now, the second part, it is dedicated to comparative analysis and unit-specific activity. It is the reflect of the accreditation. We have chosen only European units that contribute for more than 150 lung resection over the last 3 years, in order to be perfectly compliant with the accreditation. What can we notice? There is in this year's Silver Book 243 units across Europe that contributed. Among them, only 154 contribute for more than 150 patients. However, when we look a little bit more in depth, what do we see? That those data are really unbalanced, with a major risk of bias, because 45% of the data they come from France. It is not written, but Zalan will be happy to know that 17% of the data comes from Hungary. So among time, those huge impact of France is slightly decreasing, but nowadays it is 45%, and that can bias the results. We need to pay attention to that. Now, what about the satellites? The third part is dedicated to the Thymoma section. It is the third edition, thanks to the effort of the Thymic Working Group. This year, we were able to upload more, 300 patients more, reaching 1,300 patients in all. It is very, very good results for these rather rare tumors. The problem in the Thymoma section was, by the past, a huge amount of missing data, but as you can see on this slide, there is an increase in completeness over time since last year and since the year before. So we are on the good way for the data completeness. There are only 12 mandatory variables in the Thymoma core dataset. So please, if you enter a patient in, at least add and fulfill completely those 12 variables. The fourth part is dedicated to the mesothelioma section. That is the second edition, thanks to the huge work of the mesothelioma working group. We upload this year 220 more patients. That is in all 2,216 patients. 63 units across Europe. Positive point, we signed a data share agreement between ESTS and the ISLAC in order to contribute to the 9th TNM edition. Negative point, huge amount of missing data. We are currently working on that in order to improve the data completeness. And another point, I feel that there is a slow prospective increase each year, and we can do better. The last and the fifth part of the Silver Book this year is dedicated to the neuroendocrine tumors section. It is new. It is the first edition, thanks to the neuroendocrine tumor working group. We were able to upload 1,400 patients. Many of them are retrospective, and we will see how it works prospectively in the next years. However, it is, for instance, the largest series of lung nets ever collected with, and it is important to be said, a high data completeness, 85%, yielding to nice scientific validity, an important scientific validity. So, what can I say to you to summarize? First, Currently, the ESTS database is in a mature phase. It is still growing, plus 15% since last year. In 2016, for those who were there, I was pleased to announce the milestone of 100,000 patients in. In 2018, we reached 132,000 patients in, with a new milestone of 100 patients that have undergone lung resections. However, large European contributors are still missing, and perhaps they will recognize themselves if they are in the room. What is important? That's what is the reflect of the quality of care. It is that the 30-day mortality of the database, the entire database, decreased along the study period by 2%. This will lead to my last message, that it is the most important one. All the outcomes measured with any kind of feedback programs, benchmark, self-assessment capabilities, such as all those developed by the ESTS database and K-data, such as the clinical care analysis, all those programs and benchmarks, they are effective in improving the surgical patient safety and patient care as a whole. It is a kind of virtuous cycle of quality. The longer you belong to the ESTS database, the better you become. My final proposal would be the following, that the regions and the presidents of national society, they should lead by their participation in the ESTS database. They should encourage also national participation, or at least any kind of contribution to the database. It should become an obligation, I would say a moral obligation, for being eligible to be part of the ESTS Council. I thank you for your attention.
Thank you very much, Pierre. As you told before, we could have the discussion later. Okay.
As you want.
As you prefer.
As you want.
Any question?
Any burning question? No. So at the end.
So at the end. Okay. So we can move to the second presentation. And in this case, our Secretary General will update about the institutional accreditation program.
So thank you very much for the invitation. The database session has become a tradition at the ESTS meeting. This is very important for us. And this talk is about the ESTS institutional accreditation, which was started by the Society in 2011, and which is aimed at improving quality of care and standardization. This morning we discussed and we talked about standards of care, standardizing the different phases of the perioperative care, and our purpose with the accreditation is to offer an instrument to encourage standardization of practice. And it is basically the accreditation a quality label. There is no political meaning attached to it, and it is not prescribing. It's just an indication that you perform according to recommended standard based on evidence. And if you believe that this is redundant, I show you these slides, which is the proportion of patients with DLCO measured before lung resection in those units with calculated CPS. So you see the extreme variability from one unit to the other, despite the guidelines, functional guidelines, European, American, recommend a systematic measurement of DLCO before lung resection. So that's why we push on the accreditation, because we hope that with accreditation we kind of offer an educational also elements or program to improve standardization. The same for the proportion of patients candidates to lung resection with clinically staged N2 disease undergoing pre-op invasive mediastinal staging. You see some units do very well, but some others, they do not stage the mediastinum before the lung resection. So we certainly need to improve the standards. And when we discussed this morning how we can improve perioperative care, I think we can do better in Europe. These are the eligibility criteria. There are some changes compared to last year. First of all, the volume. We need a minimum volume of at least 150 anatomic lung resection performed or recorded in a database during the last 3 years. And last year, this criteria was 100. So we increased by 50 resection. This is an average of 50 resection a year, which is not huge. It is not too prescriptive. So far, the accreditation is limited to European unit. Obviously, the chief of the unit, or at least the clinical audit lead, must be an ESTS member. And then the composite performance score that we use to assess the performance must be positive, greater than 0. And then we introduced, since last year, an element of quality of data. So we need a completeness of variables used to calculate the CPS at least greater than 70%. So this year, some units were eligible according to the CPS, but when looking at the completeness of variables, for instance, to calculate the Eurolung 2, the predicted mortality, the completeness was less than 50, sometimes 40%, which means at the end of the day that the CPS is calculated not on 150 minimum, but on a much less or smaller sample of patients, which is totally unreliable. So this is and I think 70% is sufficiently is a trade-off between volume and quality, but we can even be more prescriptive, if we wish. It is not just outcome and process. We also have some structural characteristics that we assess by auditing the units when they are eligible, and we basically these characteristics are based on this paper published in 2014, which illustrates the minimum requirement for a structural unit to perform general thoracic surgery in Europe. Composite performance score is a combined combined score is a number at the end which combine several processes and 2 outcomes which cover the different phases of the perioperative care, so preoperative, intraoperative, and postoperative. The postoperative obviously are the risk-adjusted morbidity and mortality rates, and you see the other elements. For the morbidity and mortality models, we now use since last year the Eurolung, which is derived, the 2 models, from more than 50,000 anatomic lung resection. And these are the equation, if you just want to take note, but this presentation will be then PDF'd and uploaded in the website, just to be available for the members for their review. This is the timing of the accreditation process. We revised this last year, and I think it worked quite well in terms of timing. So the CPS is calculated centrally, so it is not on demand. So it is not the unit that requests ESTS to calculate CPS. It's just automatically calculated in May. And actually, each of you, any of you who are using the database, can read their CPS online, real time. And then the eligible units are announced during the ESTS meeting, like we will do at the end of this presentation. After the meeting, we will send out the invitation letter officially from ESTS. Then a unit is free or to accept or not, because the accreditation process has a cost, which is €1,500, which covers the administrative cost and inspection. For those units who wish to undergo to the process, there will be a local inspection and audit. And I wish to thank K-Data to help in this, and Stefano Passani in particular, who did a great job in inspecting, the 5 units this year. Then the auditor report to the database committee and the council, and then finally in May, so during the meeting, there will be the announcement of the newly accredited units with the certificates given. This is an example of the report, which is generated by the auditors and which is reviewed by the database committee and then approved by the council. And this is the basically the screenshot of what each unit can see from their laptop, from their desktop, in terms of composite performance score and completeness of variables. So everything is available for you to correct and to improve the performance and the data quality. So there is a feedback in this regard. This is the list of currently accredited units for which the accreditation has not expired yet. You see the new unit which will be awarded today at the top of the table. And then we have the other units. You can read it. In some cases, you see, the year in bracket is the year of the first year accreditation. Then the recertification is just an administrative process if the CPS is positive. But then after a 6-year, all the process need to start again. So the unit need to apply again for the certification. This is the list of units eligible for accreditation 2019. So Torino, Toulouse, and Dijon. And these are according to the criteria that are listed above the table, which are a little bit stricter this year. And you can find all this information in our website, and well, you will find also this presentation uploaded in the following days. Thank you very much.
Are there any questions concerning accreditation? No. In that case, I will call my colleague, Dr. Salati, to give his talk concerning the merging of databases.
Dear Director, dear colleagues, good morning. First of all, I would like to thank the Society for the opportunity of presenting this project that started last year when ESTS had the chance to include within the ESTS database some external data coming from the Italian VATS group registry. Well, I think this is a very interesting project because for the first time ESTS instituted a specific commission in order to verify several technical aspects as well as the reliability and acceptability of external data before merging them within the structure of the ESTS database. But before describing in details this project and the steps of this project, I would like to spend some words in order to describe what the Italian VETS Group Registry is and what it would add to our database. Well, the Italian VETS Group Registry was conceived in 2013 and then developed and delivered online in 2014. In this picture here, you can see the founders of this registry that nowadays counts 49 different Italian thoracic surgery units as contributors. This registry collects data about a specific subgroup of patients that are those ones submitted to a vasculobectomy procedure, and to be included within this registry, the vasculobectomy procedure should satisfy some minimal requirements that are represented and reported here by a thoracotomy with a maximum length of 6 centimeters without using a rib spreader. The hilar elements should be isolated and resected one after the other. During the procedure, you should perform at least a systematic nodal dissection, and the specimen should be extracted using an endobag. At present, more than 6,000 patients are collected within this registry, and the hem of this database is reported within the dedicated website by the founders that stated the goals of this registry. As here reported, they wanted to verify the risk and benefits of the vasculobectomy procedure and its oncological results. They wanted to verify the safety for the patient and the economic impact for the hospitals. And finally, they would like to increase knowledge and education about this procedure in order to promote its dissemination in Italy and worldwide. Well, once I've described this registry, we can have some more information about the project that we performed, and these are the steps that we conceived in order to verify the reliability of the Italian data. The first step was the evaluation of the variables agreement between the two different registries, the Italian and the European. Then we verified the data quality of the Italian data in terms of completeness. And finally, we performed an evaluation of the accuracy and reliability of the Italian data through a process of direct data source verification into different contributors to the Italian VETS Group Registry. Let's see the first step, that was the variables agreement evaluation. In this case, we wanted to verify if the two registries were describing the real world that they wanted to represent, that was the real world of the vasculobectomy procedure, using the same language, using the same variables. And as you can see here, the ESTS database counts more than 100 variables for describing the lung within the lung section, and 93 of them are specifically dedicated for describing the lobectomy procedure. On the other side, the Italian VETS Group Registry counted more than 300, and now in the second version, more than 400 variables for describing the vasculobectomy procedure. This gives you an idea of how much this registry is focused in describing this subject. But the thing that is more important is that 85 of these 93 variables collected within the ESTS registry are collected in the Italian one using exactly in the same way. So there is a very high level of compliance among the two registries, and this compliance is even higher if we refer to the lung core variable subgroup that are those variables most important for ESTS because used for the calculation of the composite performance score.
The second step was the data quality assessment. Ideally, the overall completeness of the Italian VATS group registry should be 100%, because in order to include a new patient, a new record, and inside this database and save the procedure of uploading, you have to fill all the fields that are reported within the online data set. But going a little bit more deeply in analyzing the design of the database, we found that some section of this registry can be skipped if the patient doesn't have the correspondent real data. So at the end, we stated that the overall completeness of this data set should be around 90 to 95%. That is anyway a very good level of completeness if compared to the one that we presented in a paper in 2015 for the ESTS database lung core variables, where we found a completeness rate of 80%. And finally, the third step was the evaluation of the accuracy and reliability of data, of the Italian data. And in this case, we had the chance to perform a direct inspection and a formal inspection in two different thoracic surgery units, contributing also to the Italian VATS group registry. And we could verify not just the facilities for performing the VATS lobectomy procedure, but also the facilities for collecting data about the VATS lobectomy procedure. But we could also verify if the data uploaded by that unit to the Italian VATS group registry were consistent, were compliant with the ones registered within the data source that was the clinical charts. We performed two different inspections, and borrowing some methodologies already developed for the institutional quality certification program, we could verify that the overall real completeness of the Italian data was quite high, 92%, and the overall accuracy very high, again 92.4%. So summarizing, if we go back to the three steps, you can see that the VATS group registry has very high level of variables agreement with the ESTS registry, a very good data quality level in terms of completeness, and a very high accuracy of data. And these results were reported within a final document sent to the ESTS Council that ratified the good data quality of the inspection for the Italian VATS group database. The Commission thought that this methodology should represent the pathway for future data merging processes every time some external institution or societies would add or would offer their data for merging them within the core of our database. Finally, I would like to thank the chairman of this project, Professor Gaetano Rocco, as well as Professor Crisci and Dr. Bertolaccini of the Italian VATS Group Registry for their kind help. And thank you very much to all of you for your attention. Thank you.
Are there any questions from the floor?
Anyway, I have a question about the, so the process now is to import, and the reason why I'm asking this is just because this could represent a template for other groups, other societies. So to import now the retrospective data, so what all data that are now in the VATS group database, and then to carry on annually. Is there an agreement or is there a project for future inspections, or is there an ongoing audit? And the reason why, again, I'm asking is just because, this could represent an example, and I think it's a good example, to a template for other societies and other groups.
Yes, this is a first attempt in defining a methodology for uploading external data in the future, coming from societies or also from national societies or institutions in the future. Obviously, once you have verified these three different levels of acceptability, you have to implement a process for actually import the data. And I think that the simplest way could be, as we already are doing for other societies, import once a year data that are uploaded in the original database prospectively. So if we look at this database, the Italian contributors upload prospectively their own data in the Italian VATS group registry, and the ESTS could incorporate once a year this data within our registry. It could be a solution, I mean.
So how often because you are an expert in data quality, how often you would you think an audit or re-audit of the data in cycles would be needed? So because now we import the block, and then perhaps we import annually, and then perhaps we wait 1, 2 years, or 3 years. Because the reason why I ask is because the audit process is costly.
Yes, it's costly. Yes. So
that's.
I don't know. This is the same for every other institutional or society. Oh, sorry.
I think one solution could be a remote audit if we need it.
Well. Yes, in this case, you are not. You will skip a phase that is the, how can I say, the direct inspection of the data that gives a lot of power to the reliability of data. But obviously,
Gaetano,
it implies
you want to say something?
A cost.
Yes, perfect. Thank you very much. I want to thank Michele for the fantastic job he did with me. It was a fantastic help. It was a difficult task. What we're going to do is to create a template and write it down, hopefully published in the European Journal, so that whoever wants to approach the issue of validating data from a data set they have available on whichever procedure they have. Of course, they will have Pierre Emmanuel and yourself and the committee as a reference to guide the process. I would think either remote auditing or with more, how can I say, stringent linking of our clinical activity to the need of participating to the database will create the possibility for everybody to actually access this potential that the ESTS is providing, because it's going to be the future. We cannot be practicing tomorrow in a unit which is not accredited. So this is one thing. The second thing is we cannot think about new procedures without the actual proof that they are valid, and the database is a fantastic tool to do this. So it's going to be maybe every year, every 2 years. We have to find the sponsors. We have to find the funding, because this is going to be mandatory for our future practice.
Chris, how does it work with the STS? Do you have an audit system or?
There's a since 2012, we've been performing systematic audits on the STS database, and it's done by an external company. The way that it works is each year, 25 participants or 25 participating centers are randomly chosen. Of those 25 centers, each one of them have 25 cancer cases, which are then pulled out, and the medical record is examined against the STS, General Thoracic Surgery database. They examine 40 different variables for each of those 25 cases. So each year we audit 25,000 data points. That's been going since 2012, and our agreement between the electronic medical record or the medical record and the STS database has been between 93 and 97% each year. So
who is paying for this?
The STS pays for that.
What total percent of the data is checked?
Well, we have 309 participating centers. I don't know the exact answer to that question, but each year, if we're doing 25 centers a year, it's 7 or 8% of the centers per year. We've been doing it now for since 2012, so 6 years. So eventually, we end up getting back around to auditing all centers, but again, it's a sampling, of course.
Sorry, gentlemen. Last remark, William.
Last
and then
question.
We need to go because
yeah, I understand.
Very late.
I must congratulate you on your completeness of the data, but in the beginning there's always the danger of selection bias. So I'm a little bit puzzled why you choose only the VETs and not the whole scope of cancer surgical treatment. And the second question is the 49 centers, is that the whole of Italy or is that a selection of a part of Italy?
Well, the selection in terms of the subject is just because this registry is designed just for VATS lobectomy procedure. We didn't make the selection, they do that. The participation to the Italian VATS group registry is voluntary, so it represents a sample, maybe. Not all the units, Italian thoracic surgery units are participating to this database.
Okay. Chris, I will invite you to give your talk about the STS, ESTS data transfer agreement. What until now we have to overcome?
Okay, so I'll try to make it as quick as possible. Since we're running a little bit behind here, I appreciate the STS inviting me to speak on this topic, and the data transfer agreement is something we've been working on for the last 2 or 3 years and come up against multiple challenges. I have no financial disclosures. As a quick overview, the STS General Thoracic Surgery Database is the largest database in thoracic surgery. It was established in 2002. As I said, it's audited and it's voluntary for participating hospitals. Participation has increased each year, with 306 participants contributing to the fall 2017 data harvest. And as of the end of 2017, it included 970 surgeons at 290 American institutions and Canadian institutions, and 2 international sites other than that, for a total of over 500,000 operations. The STS database was developed for the same purpose as the ESTS registry for quality improvement, institutional benchmarking, and surgeon education. Given the similar purposes of the organizations and general organization of the two groups, collaboration between the two databases seems like a very natural fit. As we mentioned, since 2012, the STS and ESTS have published 2 joint papers, the first in 2015 describing the harmonization of over 60 variables between the two databases, and the second was published the following year examining intercontinental variation in pulmonary resection practices. These papers acted as a catalyst for future studies. However, most additional studies require the creation of a joint data set with patient-level data. But think of the potential for collaboration. We could combine the two data sets to have huge cohorts. There's a number of different studies that we could do. We could assess the modern perioperative morbidity and mortality for stage 3A non-small cell lung cancer with induction therapy. I think we all think it's safer than some of the data says. We could define a modern preoperative FEV1 and DLCO associated with increased perioperative morbidity and mortality in the largest group that has yet been seen. We could do comparative studies. We could perform an intercontinental comparison of preoperative lung and esophageal cancer staging practices and see if they're different between Europe and the US, and is there an association with pathologic upstaging or downstaging. There's a number of different projects we have two different risk models for lung resection. ESTS has one, STS has one. We could see if the ESTS model has fewer variables than the STS model. We could see what variables are driving those models. So the possibilities are nearly endless, but what has kept us from moving forward then in these last 2 to 3 years is certainly not the goodwill of the surgeons who are interested in collaborating here. The main reason has been the GDPR, as you guys have heard, the General Data Protection Regulation. It's a new regulation in EU law, as many of you know, that aims to protect the privacy of citizens in the European Union. Although it was adopted in 2016, it was not enforced until just 2 days ago. And the purpose of the GDPR is to standardize data protection regulations, making it easier for non-European companies and organizations to comply and also protect the information now of the European citizen. Now, interestingly, it applies to any information relating to an individual. That could be private, professional, or public. It could be a name, a home address, a photo, an email address, social media posts, medical information. They all apply. The reason that everyone is so nervous about the GDPR is violators run the risk of being fined up to 4% of their worldwide revenue, or 20 million euro, whichever is more. So that's a gigantic potential fine, and so everybody's quite scared of that. However, this only applies to identifiable data sets or identifiable information. And the STS, is the way that we're trying to move forward with this data transfer agreement is by obtaining assurance from the ESTS that the patient data that we combine will be completely and irreversibly de-identified. And if that's the case, our understanding is that the GDPR will not apply. There have been other questions that have been raised about secure data transfer across international borders. In looking deeper into that, at least for the initial projects, it appears that the easiest way to do this would be to set up a box folder that the ESTS could dump data into that would then be directly transferred to DCRI, or Duke Clinical Research Institute, where that data would be securely held, processed in a pre-specified way, and then fed back to, the data would be fed back to the ESTS and STS data task forces, database task forces for publication. Once a combined data set is created, there remains uncertainties regarding the controls that would be put on the use of the data. The first data transfer agreement between the two societies will likely reference the standard clauses approved by the European Commission in 2001, which generally relate to the data importer, which would be the STS, abiding by a number of regulations to ensure good communication, lay out processes in the event of sub-processing if that was required, and fulfill their obligations to the data exporter, which would be the ESTS. This data transfer agreement that's yet to be created must also define who will own the combined data set. Both societies generally agree that the patients own their personal health information. However, they give ownership of the aggregate data to the societies. So maybe some sort of reciprocity clause providing joint societal ownership of the data would be appropriate. And then expectations regarding balanced visibility. And so presentation at both international meetings, both here as well as in the US, equal number of authors on presentations and publications, things of that nature. And then finally, what should be done with the data once the pre-specified projects are completed? Should we destroy the data? Could it be used in the future for agreed upon projects? These are things that should all be laid out in this first data transfer agreement. So, although the drafting of the first data transfer agreement is quite labor intensive and expensive, potentially expensive from a legal standpoint, we do believe it's a worthy endeavor because it will provide a template for future intersocietal collaborative efforts. There are often more questions than answers when new ground is being broken, and that's what we're trying to do here. A combined data set between the STS and ESTS has never been created in the past. There's no precedent to do so, and there's no templates to reference. Having the ability to combine these data sets has great potential to improve overall thoracic surgical care and to get to the bottom of some really interesting questions. So we believe it's an exciting time as new trails are being blazed and templates are being forged that will be used in future collaborative efforts between the STS General Thoracic Surgery Database and the ESTS Registry. And I thank you all for having me here.
Any question from the audience? So we could move to the next presentation, where we could understand what ESTS database could learn from others, and in particular from the Dutch lung cancer audit database. Please.
The former one, please. This is the next one. This is the Brazilian one. Stope. 2 down. Thank you very much, Chairman, to give us this podium for this database session. We Dutch are known for our controversial behavior sometimes, and you can put it on the negative side and the positive side. I hope after this presentation I hope to convince you that we put this on the positive side of the Dutch proposal. There's been a lot of effort, especially from research fellow Lisa van der Woude in this presentation, and all the others who contributed. I have no financial disclosures. We have a rather different philosophy on the aspect on databases, because we strongly believe in the process of auditing. And auditing starts with identify a topic, then make a standard set, collect the data, that's in fact a database, but also do a data analysis, but most important, implement some changes, whatever you get output from those data. And that's why it's called an audit. And in fact, it was an American surgeon in the early 1900s who started this philosophy. But it's very interesting to know that his fellow colleagues didn't like his idea. He was rather neglected and discouraged to publish or to present comparative data. And that's the problem. That's the primary reflex. In my situation, in my surgical department, in my hospital, there are no problems. But the problem is, aren't there any problems, or you don't see them? And there's a famous quote from a British guy who said that surgery without audit is playing cricket without keeping the score, and that says it all. Then it's all a game. The basis of clinical auditing is it's not just a database. The basis is that you give a proper feedback, that you do benchmarking, comparison to other centers or other countries, in fact, and you have a transparent attitude. Something about the evaluation of the Dutch Institute of Clinical Auditing. It started with a surgical group who wanted to do in colorectal cancer. and that started in 2009. In 2012, we started with the lung surgeons. In 2013, our radiotherapists joined in, and in 2015, because we have a separation to doing lung surgery between general surgeons or thoracic surgeons and cardiothoracic surgeons, and we merged, and now we have a combined complete overview. But most important, in 2016, our pulmonologists joined. So that gave us the opportunity that we have in Holland a full-blown overview, complete insight of the treatment of lung cancer on all levels of treatment. I skipped this slide because we have, in fact, 3 separate databases, the surgical one, the radiotherapy one, and the lung pulmonologist one. Of course, this whole institute that coordinates this system is rather complex, it's expensive, and it needs a lot of committees and people involved and looking at all the data, etc. But the basis is the clinical audit board, and especially the scientific committee within the lung surgical board or the radiotherapy or the pulmonology board, and that's mainly clinicians, and that's very, very important. But how do we audit and how do we do it? It's a web-based registry, or you can do it case by case in the web, or you can collect your data and do it in a batch system every week or every 2 months, whatever you want. It's only about lung cancer and metastacectomies, mediastinal surgery. It's excluded lung transplant and esophageal surgery or cardiac surgery. And of course, a data set that's comparative to any other data set in the world. It's an immense set of data that we collect. We are a very small country, and nowadays we have 43 centers doing lung surgery. And when we started this whole auditing process, we had 72 centers. And only because of the auditing and the insight and the mirror information, people decided, okay, perhaps we or my hospital or I should stop doing this kind of surgery or find a partner to merge and combine your capabilities. But the future is even stronger. We want to minimize it to about, I don't know the exact figure, but we want to concentrate this kind of complex procedures. The input is like any other web-based, that's comparable, like any one STS or ESTS. But why do you collect? Mostly important because of feedback and benchmarking. And for example, if you want to know what's the ACEs score of your patients, you can see what's your patient group compared to the rest of the Netherlands. And that gives tremendous insight. But most important, is that you can see by using the funnel plot system that where your hospital is standing in the rest, comparing to the rest of Netherlands. In this case, the red spot represents your hospital. The curved blue line is the confidence interval, so you have to be inside the confidence interval, and the green line is the national average. So you can compare yourself with your results if you're above, low, or whatever. And mirror information is very, very important. The data quality is of course guaranteed, as we heard before, by the completeness of the data and how much percentage of the data can you analyze in fact. And last year it was 98% in fact, not 97%. But there has to be a whole data management team. There's a lot of research and uses of the data coming out of this database. And most important, there's also a verification process, as we heard from the STS also. It's completely comparable. We select all the hospitals and we check if the completeness of the data is okay. This was, I think, about 3 years ago, and this curve is going up, and it's almost reaching 95%. We do it a little bit different. We select a group of hospitals, random, and we take a local visit in the database, in the local electronic patient record or paper patient file, and we check all the data, especially on some items that are most important. For example, if there's any missed mortality. And in 2016, that was 0% missed mortality for the 14 hospitals selected, and there was only a 3% not or wrongly registered percentage of complications. We do this cycle every 2 years, and the 14 hospital that's been selected the previous session will not be selected. So there's a natural cycle that we cover the whole hospital system. Why do you measure so many things? That is obvious. You have to do a case mix adjustment. You have to see if there's a growth potential and if there has to be some changes in the organization of your hospital. And most of all, you should consider that it's not what we call an audit, is not to create indicators for other people. It's not a machine to get to that point. But indicators are very, very important. But indicators are dynamic, and so are data sets. And there's always a change of case mix. There's a change of population or change of whatever. So you have to be aware that you should take into consideration that you could change in time the indicator that you find interesting. It's more than outcome. You have to have a structure analysis, and you have to have a process analysis. And how a good indicator, it must be relevant, it must be valid, it must be reliable, it must be feasible, it must be representative. That all seems obvious, but you have to be aware that it is indeed so. The most important thing is that when we talk about quality discussion, it's mainly focused about the professional association, being the surgeon or the physician itself. But we really should take into consideration that the people who pay for it, the insurance companies, for example, but most important, the patient organizations, that's why we do it for, we should take them into this process and do it all together and involve them. And that's where the DICA has its role, because it's a really professional organization that can help it all. So what's in there? What's all the 6 years of data collection on the lung surgical field? There's an immense growth of data, and now joining with the pulmonologist, you can see that we almost cover every lung cancer in Holland. Well, the percentage or the distribution of all the surgical procedures is not different than any other country probably in Europe. This is interesting that it's not, lung surgery is a really sometimes tricky business. There's a relatively high complication course, and the mortality, 30-day mortality in Holland is still relatively low, and I think it's very difficult to get it lower and lower. Other things that are very interesting is, for example, if you look at multidisciplinary treatment boards, that when we started in 2007, there was a very broad variation of the hospitals who did all these on a patient level, and then the wideness of the variation decreases, and so now we have an extremely high level of MDT for every individual patient, and the indicator for this year will be 100%. I'll skip this one. And what's happening with the data? That's the third part. It will be transparent to the public, to the insurance companies, to the hospitals, to the physicians, to the government, and that sort of thing. And we can analyze outliers, and we can do a tremendous effort of research on it. The transparency portal, that's an official website where everybody can look, and all the contributing partners, they can decide which one in collaboration will be presented on the transparency portal. So the scientific association and the patients have the leading roles to decide what will be presented as transparent. But as always, the thing about statistics, people always say, well, my hospital is different than yours, and it's not true, and whatever. But we are in the possibility to identify the outliers in the negative way. We have to take a look on it, but also on the positive way. Can we learn something for the good performers on the lower side of the confidence interval? And that's the same when you talk about concordance between the clinical staging and the pathological staging. We found it very disappointing that we only had about 45% of concordance between our clinical staging, which reflects the way we treat patients, and the outcome in the pathological staging. We have a lot of research. We have a continuous turnover of enthusiastic research fellows. There were 307 DICA publications recently selected out from PubMed. We have 8 PhD research fellows only on the lung subject, but the total crew of the DICA is about 35 people, so it's not it's a really professional organization. Of course, we have the costs. First, the hospitals paid for it and the insurance companies. Later, only the insurance companies, because the hospitals didn't want to do it. And in the future, it will be completely financed by the government and the Ministry of Health, together with the health insurance companies. And of course, we hope in the future that with the collaboration with the ESTS and perhaps European funding, we can really come to a European database/audit. In summary, the cornerstones are the leading role is for the clinician, not the government or anyone else, and the patients. Frequent feedback is really, really important. All stakeholders should be involved. Nationwide implementation, unbiased information, and transparent on your results. What we achieved, you have a national insight of our quality of care on lung cancer, and that makes it more easy to interpret it, what's our level of care compared to literature. The literature is always a variation between whatever 10 or 30%, and we know exact the figure in our country, what's our quality of care on various indicators. And it also makes it possible to change things. For example, the TNM8 change, it can be very difficult, but this kind of database makes it easy, especially with the collaboration, to change to the system. And most important, the control of the transparency program stays within the clinicians. They decide. There's an intrinsic motivation, and that's because of the weekly or monthly or whatever term you want to take, to review your results. It's mandatory, that's the external stimulus, so it's not voluntary anymore. And from procedure-based, is only looking at the procedure of the surgery, we go now to the patient as a center focus. The challenges is, of course, the registration burden. That's always for databases, whatever database you talk about. And, of course, the privacy legislation, that's discussed it already, that is really a really big problem. Future perspectives is, of course, to optimal use all these data. Multidisciplinary, we strongly believe in that we took the whole scope of treating the patient with lung cancer and not only the surgical procedure, and take into account the patient perspective in the patient-reported outcome measures, for example. And perhaps in the future, international audit. Of course, value-based healthcare has to be implemented, and we already started a program to look at the costs of complicated procedures versus non-complicated procedures, and you all know the outcome already, that will be on the benefit of non-complicated. In conclusion, you only can do quality evaluation, then you can improve yourself if you implement some changes. And what matters most is, this is how we see ourselves. We are a pussycat, we want to be a lion. But if you really look at the data, you'll be surprised what comes out of your own hospital. Thank you very much.
Thank you very much, Willem, for your very nice and also informative talk. I'm sure you, as a Dutch, should serve as an example for what we have to do in the ESTS database committee in order to try to increase the quality of care. Thanks. Any questions? Gaetano?
That's a very interesting presentation. For the ones in the audience who are not accustomed to what the Netherlands are the place where the SBRT movement started and was brought up with strength, especially from the University of Amsterdam. So this data that you are presenting, surgical data, are extremely important because we've been witnessing in the past in the literature, SBRT literature, reporting data on the surgical performance, which were, say the least, a little bit doubtful. So you have to talk to patients. You have to tell them which are the risks of procedures. How are you going to implement this data into clinical practice in order to face competitive or alternative treatments?
Well, that's a good question. But that's why it's so important that you have a multidisciplinary board discussing every individual patient. And there is a strong variation in where you've been treated in the Netherlands. For example, in Amsterdam, the SBRT is very high, but in other centers it's not. And it's important to collect those data, but it's still known, but that's known from any country, that there's within a country, there's a lot of variation of how a patient is treated. And with this data, we can show them much better, sure. But I must, how do you call it, geruststellen, how do you, reassure you that there is a strong movement from the lung surgeons against the SBRT, and mainly based on that there's a lot of percentage that don't have any pathology. And with the immune era coming ahead, we need pathology.
Gonzalo?
Yeah, you've been talking about insurance companies and patients, and of course clinicians are sharing maybe not the whole contents, but the results or the outcomes and all that. When I'm hearing about insurance companies participating in medical databases, I'm afraid that due financial restrictions, some patients can be excluded from paying for surgery. I'm talking about high-risk cases, for instance. How do you manage this problem with financial, with insurance companies?
First of all, it's mandatory. You cannot do a selection of your patients you put into the database, and that's because of the verification process. And the health insurance companies emphasize also that the data you present from your hospital have to be complete. So the selection bias is not possible. And it's not that the health insurance companies decide what treatment we can do. We decide as clinicians, but they only sit at the table together with the patients, especially what kind of indicators we find for this year, next year, whatever year. We come together twice a year with all these stakeholders to discuss all these outcomes and all the plans for the next year. So we're not so afraid that the health insurance companies would direct financially based all this kind of stuff.
I think we have to go forward. To end with this interesting session, I will call Ricardo Terra from Brazil, who will give us the new insights from the Brazilian database.
Well, good afternoon. First, I'd like to thank the organizing committee for the opportunity to talk about the Brazilian database and giving you an update in this more mature phase. These are my disclosures. The Brazilian Society of Thoracic Surgery database was implemented in 2015 in a partnership with ESTS. At that moment, we designed a project in which we divided the implementation in 3 phases. Phase 1 was implementation of the platform, phase 2, escalation, and phase 3, the maturity phase. In phase 1, we basically started collecting data. We started the platform and then started collecting data in 5 institutions. In phase 2, we invited more institutions to participate. We invited 10 centers, 7 of them eventually joined. And probably the most important result of this phase was that we were able to elaborate an annual report. The annual report was distributed to our members of the Brazilian Society last year during our national meeting. And for the first time, we had real-life data of what was going on in Brazil in terms of thoracic surgery, not only demographics, but outcomes and so on and so forth. And in this meeting, we actually ended a cycle, and we presented to our members the first results, and actually we updated them about the status of our database. We held also educational sessions, since databases in Brazil were not common, and ESTS members like Dr. Brunelli and Dr. Salati were there and helped us a lot and supported a lot our initiative. Currently, we have 16 institutions registered in the ESTS, in the Brazilian Society of Thoracic Surgery database. However, only 10 of them are active. And by active, I mean institutions that contributed with at least 5 cases. So we are in a more mature phase now, and we are facing new challenges. We are facing challenges with participation, with the possibility of publishing our results and analyzing them, quality of data, and also in where we will get with our database. As for participation, we are actually very happy to see that in 2017, more than 2,000 cases were included in the database. It was more than we expected. However, looking into the details of the institutions that contributed, we see that out of the 10 institutions participating actively, 6 of them are contributing in very consistently. However, 4 of them contributed and then either quit or reduced drastically the contribution to our database. And one of the concerns with this is the fact that most of the new members were those that either quit or reduced their contribution. Only one of the 7 new members is actually contributing in a consistent way. And this is concerning because we have many people applying for participation in our database. We have 3 centers that are already finished their application process, one even from Colombia, an international member, and many more applying to participate. As for scientific activities, we have been presenting several papers, several posters all over, and also we have 2 papers published this year with the results of our database and more to come. And one of the challenges we are seeing now is the fact that we need more people involved. If you look at the names, they are the same, and they are repeatedly the same names, and we need more people engaged in scientific publications and scientific analysis of our database. However, it is exciting to see that more people are involved and more people are interested in databases research. This is an example. This was a paper published by Dr. Lauricella in São Paulo that it was proposing a new metric to monitor data quality. This was published in the Journal of the American College of Surgeons and shows that, well, we are getting there. We are getting to the forefront of the field, and hopefully we'll have more people also involved in the educational and scientific activities of our database. As for data analysis, we focused on 2 of the conditions, lung conditions and tracheobronchial conditions, because they are very frequent in our database. And specifically for the lung conditions, the main thing we wanted to know were the outcomes of our lung resections. And we used EuroLung to compare our results to using the risk-adjusted model. And we were very happy to know that calculating the predicted mortality and observed mortality, the curves overlap. And so the results of thoracic surgery in Brazil are in line of what is expected in Europe. Another interesting finding was the fact that 44% of the cases were doing with VATS. And that also stimulated us to look at the results of VATS in Brazil, and we used propensity-matched analysis to compare VATS and open procedures, and this paper just came out. And in this paper, we, similarly to what was reported in Europe and in North America, we showed that complication rate was lower using VATS also in the Brazilian setting. And one interesting finding was that for benign diseases, apparently the patients benefit even more, and this is something that we are looking at now in our database. The other point was tracheal procedures. We have many cases in Brazil. It's a very frequent condition, and because of that and the limited evidence in the literature, the idea was to create a new database. Dr. Falcos has already talked a little bit about this, and we've been designing for some years a database for laryngotracheal diseases, but actually we weren't confident that it would be possible to have a multi-institutional database in Brazil. After this experience with the Brazilian database, we decided to move forward this idea and partnered with some ESTS members, in particular with Dr. Walter Klepetko, and developed new Dataset that is now being tested, and hopefully next year we'll have early results and the possibility of having more participants. Quality is also an issue. If we look at completeness rate in different groups in Brazil, we see that it's extremely heterogeneous. So we haven't been too concerned with quality so far, because the idea was to have people on board. But now one of the challenges we have is to improve data quality in our database. So the priorities in this phase 3 are increase the number of participating centers. This is something that we have been doing. To release the new data set, to work on some administrative issues like governance, including the rules of the database in our constitution, creating a website, improving communication, and particularly have financial sustainability for the database. One of the strategies we designed to deal with all these new challenges was to write down a big project so that we can apply for grants and have more engagement of more people under the title of improving the quality of thoracic surgery in Brazil by using data. We will have several sub-projects that will look at data quality, the development of a Brazilian composite performance score, which in the end will be the basis for an accreditation process in Brazil, looking at the outcomes of the main procedures and also cost effectiveness. So in conclusion, maturity has brought new challenges for us. We noticed that it's very difficult to foster participation of new members, and we have to help them and support them more. We have to understand better what is about quality in our database and improve it. Create a critical mass for data analysis and writing papers, because this is a very complicated thing now, and also dealing with administrative issues. And I like to thank the support that ESTS has given to our society and allowed us to have now a real database. Thank you so much.
Thank you, Ricardo, for your talk. Are there any questions?
something about how it's financed at this moment and what's your future plans?
Well, it was financed by our society at the very beginning. Then we were able to get some grants, like research grants from the industry. And the idea now is with this project, we are able to have more grants from different companies. So that's the only way we found to really have a continuous support.
But there's no hope or prospective idea that the government or insurance companies?
Well, it is possible to have a partial funding from the government. The problem is that we have to apply also as we do with the companies, and it is very hard to get because they unfortunately are not looking at quality improvement initiatives right now. So it's not easy to get.
Okay, let's move on. That's time for award of the accreditation. Alex, welcome. Yes, I will need your help.
When I see your presentation.
It would be nice. We are waiting for the official photographer because it's a unique opportunity to have two past presidents, one nearly president on stairs. We will wait a few minutes. If you have any questions, do not hesitate. And if you have comments, also. So I hope they will come he will come as soon as possible. So the first team for this year accreditation, I will ask to come on stairs, is the team of Marseille, and I will ask Xavier Benoit, my friend, Xavier Benoit Journeau, to come to receive the award on perhaps you can stay minutes for the...
Yeah, we can take a picture. Yeah.
Okay.
So the next certificate goes to Michael Müller, representing the Otto Wagner Hospital in Vienna.
My pleasure now to call Gaetano Rocco for the accreditation of Naples.
And, well, I need to do this. And we have many representatives from the Nouveau Hospital Civil. I'm not good in French.
With the French accent.
From Strasbourg University Hospitals. So we have 2 centers from France this year. And I guess Gilbert Massard, our president-elect, Okay?
Never.
Congratulations. The fifth center is Antwerp University Hospital. I don't know if anyone from Antwerp is here. If not, we'll send the certificate to the hospital. So, okay. Yeah?
We can perhaps make a photo. A picture, man? No?
Yeah, we can take some picture with mobile phone. So Guillaume is here, maybe. Guillaume, do we have the photographer? Okay.
If you could come to the Gallows Hall right now.